I want to ask Dr. Ramsey about this. It often comes up as to when do you place the Seton Drain and when do you take it out?
Yeah. So the thing is that when Brian knows this thing, when the biologics started, we were legitimately and for the right reasons always interested that this was going to cure the fistulas. And I think it still may. We still need to be enthusiastic. But I think the aim of the treatment of the perineal disease in the setting of a Crohn's disease has some difference of interpretation. Personally, when I have the privilege of sitting down and speaking to my patients and everything, I try to make the case to them. When these things come up, the aim is to be able to avoid them not to lose their anus or not to have them lose their ability, the continuity of their gastrointestinal tract. So that's the reason the biologics, in my opinion, dramatically, which I cannot prove it, potentially decreased the proctectomy rates, but it really helped out, but it may not have helped the complete healing rates. So I do believe complementation is very key in these settings. So in these settings, I put a Seton, and we asked to make a collective decision to gastroenterologists, what is the aim? If the aim is I'm fine with the Seton, then we like to leave the Seton complemented with biologics for a year. But if the patient is very keen on for the Seton to come out, then we give usually 2 doses of the infliximab, then we pull it out and see what happens, understanding the uncertainty. That's, again, different variation that has been our approach.
Great, thank you. Can I just ask Dr. Ramsey, maybe related to this, folks may find this important, which is, so can you maybe comment, who should, a symptomatic abscess, we know that there's a fistula, there's going to be a lot more work that needs to be done, but a symptomatic abscess, usually at the wrong time, we say, we try to coordinate with the surgeon, but, patients are painful, we may start them antibiotics. Who should or shouldn't provide immediate relief? Send to the ER, let the ER doctor drain the abscess, and then deal with the issue later, so there's time to send them to you, or how would you? So that often happens.
It's a very fair question because it's a real life. It's circumstantial, but I think we need to be educating each other because sometimes these patients go to the ER. It's very critical where to drain this abscess because the location where you drain it, that external orifice, is going to lengthen the tract of the fistula. As a principle of that thing, if you're going to drain the abscess, it's very critical making that hole close to the anal verge so the tract of the fistula, because the source is the internal os. So if you want to fix it or a Seton in the long run, having that short tract is very critical. I had my mentor used to say when it comes to anorectal diseases, I'd rather have you guys to do a right hemicolectomy alone rather than draining a complex anorectal problem. So the implications of this thing is big, but it may be interpreted simple. So to answer your question, if there's availability of an IBD specialist or colorectal surgeon, that infrastructure, I think the ER doctors should let the surgeons know rather than liberally draining these things. This is my opinion.